pleasure always to be visiting Bathinda and attending the MAPICON. My good friend Dr. Vitull has always been very, very obsessed, and he starts working on the next MAPICON right away, in fact, after the MAPICON finishes. So it's remarkable his level of commitment to MAPICON. And now that MAPICON has come to this beautiful hall, I think it is only going to move further, and more people are going to reap benefits of the academic sessions that we have in this conference. I have been asked to talk to you about the commonest public health problem that we today face. You all know we have communicable and non-communicable disorders, and as our population is aging, we are having more and more non-communicable diseases because the average longevity of life of an Indian, any student would like to tell me, males and females, what's the average longevity? Anybody? Okay, there's some inertia. It's 67 years for males and 70 years for females. And when we became independent at that time, it was about 44 years. So significant number of years you can see have been added to the longevity. And the non-communicable diseases, whether it is hypertension, diabetes, cancer, COPD, coronary artery disease, stroke, they are all actually related to age. Of course, they are related to the risk factors that we always enumerate, but they are also related to the aging process. And as we all now are at the anvil of a stage when we know that India is today the most populated country in the world. In April, the UN announced that India has surpassed the population of China. And so what we are talking here essentially is of a very large segment of people who have hypertension, and whatever we will do in terms of control of hypertension in this population, it will have bearing in the larger perspective of the world. There are some aspects of hypertension which are very important for our population. It's responsible for almost more than half of the strokes and 1/4 of coronary artery disease. And recently the global burden for disease actually was a 20-year study which has given us a lot of information regarding the non-communicable disease and so also communicable diseases that affect our country. The contribution of hypertension in terms of CV deaths actually is much higher amongst Indians as compared to the Western population. And if you look at this GBD data in terms of death and disability associated life years due to high systolic blood pressure that happen, actually is much higher as compared to 1990, what we have today. At that time it contributed almost 9% of deaths. Today it contributes almost 16 to 17%. And 4% to 8% increase. So the contribution of hypertension in terms of disability, morbidity, deaths in our population is increasing, and this is what we showed actually in the Indian guidelines of hypertension which we published, that although in 1990 diarrheal disorders, lower respiratory infections, neonatal preterm birth, these were some of the diseases of an evolving civilization. And today we have diseases like ischemic heart disease, which is the commonest cause of death of an Indian, chronic obstructive pulmonary disease, cerebrovascular accidents. The strokes have come up from 12th to the 5th commonest cause of death. So whatever atherosclerotic diseases that we talk of, actually their contribution towards, as our civilization is getting more and more advanced, we are catching up some of these diseases. Blood pressure, we wrote in an editorial in the Indian Journal of Medical Research recently that hypertension in Indians is not the same as hypertension in others. It starts relatively early in our population. There is a rural-urban divide actually, almost double the prevalence because it's not only a genetic disorder, it is also a lifestyle disorder. What you eat, salt intake, alcohol use, sedentary lifestyle, obesity, fat intake, all these things have bearing. Of course, it overlies a genetic predilection that you have for these polygenic disorders. Hypertension and diabetes are polygenic disorders. But of late, we have seen there is a rural-urban convergence now. The ruralites are almost adopting the same lifestyle as urbanites, and so India is now actually witnessing a new epidemiological phenomenon of convergence of the rural and urban divide that was happening. We know we have syndrome X, the metabolic syndrome X, which is characterized by central obesity. What is the male pattern or the apple type of obesity, which brings in hypertriglyceridemia, insulin resistance, hypertension, and even our dyslipidemia amongst Indians is different from other races. We have more of low HDL and high TGs as compared to high LDL in the other races. So our coronary disease is peculiar, our hypertension is peculiar, and obviously our management methodologies will be different. This is an area in which we have done a lot of work actually here. There is a significant variation of, in winters we have to upregulate therapy and in summers we have to downregulate, because the region in the tropics that we live in, there is wide variation of temperature that we see in the winters and summers. And of course, as I said, the average blood pressure of our population is going on, is increasing. So these are some of the peculiarities actually of hypertension that we have in our country. This is an additional very important factor actually, the environmental pollution that we are seeing today. And environmental pollution has today been linked with the non-communicable diseases, whether it is coronary disease, stroke, hypertension, because what is happening is that these molecules which are less than 2.5 microgram, they are entering through the lungs into our vasculature, and then they are generating an inflammatory process. Contribution of this environmental pollution, which you know in a couple of months in India, is a very big issue. Salt is a very important factor actually. Eating sugar doesn't cause diabetes. That's primarily, it depends upon what you genetic milieu that you have. But eating excessive salt certainly causes hypertension, and it also causes impairment of response to the antihypertensive therapy. And there was an ICMR study which said actually that an average Indian, through papad, pickles and these salty things that we have, and now this entrance of the fast foods that has happened, we consume 9 to 10 grams of salt, whereas the Western guidelines and so as our own Indian guidelines suggest that one should not have more than 2.5 grams of sodium or not more than 4 grams of salt. So we almost double. We are very high consumers of salt, and salt has a direct link with hypertension. This is a very important slide actually. This comes from the European guidelines on hypertension. And if you will notice, there is a risk, we don't have a risk score of our own, but there is a risk of coronary artery disease. We all know the risk factors for coronary artery disease are hypertension, diabetes, positive family history, obesity, smoking, sedentary lifestyle, stress, central obesity, dyslipidemia. These are the 8 risk factors. But even if someone is harboring the same number of risk factors, we have actually a YY chromosome mechanism by which our risk of having coronary disease is 1.4 times as compared to an average European. And this is because of the thrifty gene hypothesis McCaig gave, who said that our forefathers were actually living in famines. And our body metabolism actually is not able to handle the amount of calories that we are today exposed to. So with the same amount of risk factors, racially Indians have more coronary disease, more stroke, and this data has primarily come from the Western world, where Indians have migrated, whether they have migrated to Singapore, US, to Canada, Australia. World over, heart attacks occur 10 years earlier. So all these risk factors contribute towards occurrence of atherosclerotic cardiovascular disease to a larger extent, with the same milieu, same risk factors as compared. So racially we are more prone to coronary disease and effects of hypertension. This is some data which has come only a couple of months back actually, and we all know hypertension is related to disease, to the age, and as we age, an average adult who reaches the age of 80 years has a 75% lifetime risk of having hypertension. So the prevalence of hypertension increases as we age, and this is what is depicted in this pie chart. And this is data which has come last week only, which shows that today actually almost 30% of Indians have hypertension. Same data in males and females. Only about 30 to 40% of us are diagnosed, about 20 to 35% are treated, and the control levels are dismally low actually. And that is why people are now working in hypertension towards implementation research as to how we know a lot of we have a lot of knowledge about antihypertensive agents. We know a lot how to manage hypertension, how to diagnose hypertension, how to risk stratify. But the problem is it has not percolated to the grassroots level. The patients, the public has not yet got the benefits. And that is why we in fact gave the Indian guidelines on hypertension in 2019. This is a year when we are going to come up with the next edition of Indian guidelines, because as you can imagine, Indians live differently, our seasonal conditions are different, we eat differently, metabolically, genetically we are different. So obviously we will need to treat hypertension differently in our country. And this is what the classification of high blood pressure we have given actually. Optimal blood pressure is less than 120/80. You keep adding 10 to it to move from optimal to normal to high normal, and keep adding 5 to the diastolic pressure to go from 80 to 85 to 90. Hypertension is defined by the Indian guidelines as a blood pressure of more than 140/90. The American guidelines have lowered this by 10 millimeters of mercury. But world over, whether it is the International Society of Hypertension, whether it's the European Society of Hypertension, Indian guidelines, they all uniformly actually classify or define hypertension as a blood pressure of more than 140/90 diastolic. You can have isolated systolic hypertension, person can have an isolated diastolic hypertension. As we age, our vessels become more and more sclerosed, more and more fibrotic, and so systolic hypertension is a phenomenon of the elderly, whereas diastolic hypertension occurs in people between 30 to 55 years of age. Systolic hypertension is more difficult to treat than it's more resistant actually. And systolic hypertension results in end organ damage, whether it is the eyes, the kidneys, the heart, the peripheral vessels. It affects the target organ damage actually occurs much more with systolic hypertension than with diastolic. But you can add 20 to move from stage 1 to 2 to 3, and add 10 to the diastolic to move from 90 to... So hypertension grade makes a big difference, and this is what I have shown actually last year. The American guidelines came and they have just put it very simplistically. A blood pressure of more than 130/80 is actually stage 1 hypertension. And what we call as hypertension, they are calling it as stage 2 hypertension. So and by this actually there was a lot of criticism, because almost 50% of the population of America actually falls into this category, and they would be defined as hypertension. So that's for another day. But this is the guideline which has come latest actually. Alberto Zenchetti presented in June 23, and I will just talk a little bit in the next 5-10 minutes about these European guidelines, because the topic Vitull gave me is what's the current perspective, how we manage hypertension. And this is what they have given actually. They have changed the way we have to think about treating hypertension. It's not just the numbers. Look at the numbers. You move from grade 1, 2 to 3. As I said, add 20 to the systolic and 10 to the diastolic. Isolated systolic hypertension I mentioned, isolated diastolic. But look at the bottom of this actually, this slide. Stage 1 is uncomplicated hypertension, when there are no actually target organ effects. Stage 2 is when there is hypertension mediated organ damage. And stage 3 is when there is cerebrovascular disease. So you will see in the subsequent slides, it's not only the numbers, it is the other risk factors that your patient has, the age that your patient is, more the age, more are the risk of the effects of hypertension, and whether the patient has hypertension mediated organ damage or cardiovascular disorders. That is going to determine how aggressively you are going to treat hypertension. So rather than being just number centric, we today look at the other risk factors that a patient has, like diabetes, obesity, dyslipidemia. These are other factors which can cause atherosclerotic cardiovascular disease. And we also see what are the effects, whether the kidneys have been affected, whether there is proteinuria, whether there is a higher ACR, albumin-creatinine ratio. We look at whether hypertensive retinopathy is there, whether there is, so all this total holistic approach has to be made of the patient, and then you have to make a decision as to how aggressively you are going to treat your patients. This is a beautiful slide actually which is there, which I thought I'll share with you. It talks about the environmental factors, as I said, noise pollution, ambient temperature, air pollution, they all have. And blood pressure, we know, is dependent on the renin-angiotensin-aldosterone system, the sympathetic nervous system, the endothelins, the arginine vasopressin, all these, the metabolome, all these actually metabolic factors make a difference. In terms of nitric oxide is a vasodilator. We know there was a Nobel Prize given for nitric oxide invention about 15 years back. We know natriuretic peptides have a role, prostacyclin, adiponectin in obese. So all these factors make a difference. Genetic, of course, we know genetics has a great role to play. And we actually published in Nature Communications the association of autozygosity with a broad range, and we showed that there are some markers of hypertension that we can find in genetic population. So having looked at what hypertension is and what is the definition, what blood pressure levels you will count as hypertension, what levels are normal, what are stage 1, 2, 3. Let's see what is the correct method of measuring blood pressure. Because measurement of blood pressure by the medical personnel is somehow given less value, but we today know that unless you will measure something correctly, how will you manage it properly? So blood pressure measurement actually, as has been written in this slide, one should take 3 measurements, take an average of the last 2. The hypertension is diagnosed primarily by measuring blood pressure in the office. And blood pressure should be measured in both the arms. We do not diagnose hypertension solely on the basis of out-of-office blood pressure. As yet, world over, there is no guideline which says that on the basis of a home blood pressure recording you can diagnose hypertension. And this is the correct method how your patient, you should take 3 readings, as I said. Patient should be resting. The level of the blood pressure cuff should be the same as the apparatus. The arm should be bare. The legs should be uncrossed. Patient should not have had tea or coffee. These are all very small, simple things, but they have a significant bearing because they can increase blood pressure. You can overestimate hypertension in your patients. So the method of hypertension, and this is some work that we did actually, which we published in Journal of Clinical Hypertension, in which we showed that there can be a significant difference between the upper and the lower, between the 2 arms, the right and the left arm. And unless you will measure blood pressure in both the arms, you would not know actually what is the difference. And the arm with the higher blood pressure has to be taken for subsequent readings, because that's the true reflection of the person. And in almost 6% of people, you will be diagnosing hypertension, and in the others, you will not be diagnosing unless you take blood pressure in the 2 arms. And if there is a significant disparity between the 2 arms, it tells you that there is atherosclerotic peripheral vascular disease. So there are more than one benefits actually by measuring blood pressure in both the arms. Then you have the postural hypotension in elderly people, in frail individuals. You should measure their blood pressure in a lying and a standing position, because a significant fall can occur due to diabetic autonomic neuropathy, or certain drugs like alpha-methyl-dopa, clonidine. Some of these earlier drugs actually can also cause postural hypotension. So the measurement devices that we have today are, actually there has been a significant change. The blood pressure measuring device that we were using when we were students was a mercury sphygmomanometer. A mercury sphygmomanometer was invented about 100 years back, and all our life actually we have measured blood pressure in our clinics, in our hospitals with the mercury sphygmomanometer only. But over the years, the environmental side effects of mercury sphygmomanometer has come to... Welcome, sir.
Sorry, sir.
No problem. So over the years, the way we measure blood pressure has significantly changed actually. And now we depend on the automated oscillometric devices. The manual blood pressure is giving way to the automated oscillometric devices, and this is what the mercury sphygmomanometer, the aneroid sphygmomanometers can still be used, and they are actually used in a lot of hospitals. The hybrid devices, the LED and the LCD display devices can be used. But the blood pressure apparatus which is most popular today is the automated oscillometric, which sadly actually depends upon a company's specific algorithm, and that algorithm is not available in the public domain, and that's the fear actually people have, that are all oscillometric blood pressure apparatuses equally dependable? And that's a point actually which is a cause of debate and which is a cause of concern to people. So as I said, class 1 is electronic apparatus, upper arm cuff is to be used for office and home. The cuffless BP devices are becoming more and more popular, they are more fashionable, and they are going to intrude into our clinical domain in the coming years. But as yet you can see the latest European guidelines show it's a class 3 indication. So as yet you are not advised to use the cuff. They might look more attractive, they might look more fashionable, but they are not actually validated for the time being. So the cuffless BP devices are not to be used for recording, and this is actually a very significant change that happened. The Minamata Convention actually said that mercury-free healthcare had to come by 2020. And India is a signatory actually to the Minamata Convention, and India wanted to get away with all mercury blood pressure apparatuses, mercury thermometers 3 years back. But somehow the government of India has extended this because of want of dependable other apparatuses. So you will still see some of the clinics using mercury sphygmomanometers, but I'm sure in the next 2-3 years the mercury sphygmomanometers will only be a thing of the museums, and they will not be used because of the environmental side effects of mercury. It's a collective toxin, and actually Minamata is a place in Japan where multiple people died because the mercury does not get denatured, and it would go into a pond where it was taken up by the fish. Those fish were consumed by people, and children were born with multiple musculoskeletal abnormalities. Something like this happened in Kodaikanal in down south also. And so mercury apparatuses people are scared of, people don't want mercury apparatuses, and today we have this issue as to what to do because the manual devices are dependent on the mercury. And so we developed actually with IIT Ropar, we developed this new digital apparatus, what we called as the Oscar-D, a mercury-free digital oscillatory sphygmomanometer. And today actually this digital apparatus is being widely used by various places across the country. And this data actually we published. This is a second new work that we are at present very keenly and very closely doing. We are trying to develop a mercury-free sphygmomanometer which we call as merc-free. And we have published in scientific reports the whole concept, hardware, development and clinical trials we have done on this Galinstin-based mercury apparatus. Now Galinstin is half as viscous as mercury. So the size of the apparatus is going to be double the size of a mercury apparatus, which will also help you to make it more easy for your eyes to see. And we are at present doing actually clinical studies on this. We have already published this actually in scientific reports. We have a website, and we have filed for a patent which we have already actually done 2 years back. And hopefully this patent will come, and then we will be using Galinstin as the material in place of mercury, because it does not have toxic effects. This is a new type of blood pressure apparatus which is being used. It was used in the SPRINT trial. The SPRINT trial is the most popular trial which showed whether more diligent, effective control of 120 by 80 is more effective than a blood pressure control of 140 by 90. The SPRINT trial actually showed that in non-diabetic individuals, if you control their blood pressures more effectively, you reduce the target organ damage on the heart, the kidneys and the peripheral vessels. So this apparatus actually does away with what is called as a white coat effect. Whenever a patient walks to in our clinic and we are recording their blood pressure, the blood pressures are a bit high because they are a bit scared of us. So this is actually recommended by the Canadian guidelines also. This is going to become more popular, although it is more expensive. This blood pressure apparatus starts recording the blood pressure when a person is sitting alone in a room. There is nobody attending after a gap of 3 minutes. So automatically the person has rested for 3 minutes. It takes 3 readings which are 1 minute apart, and it gives you an average of the second and the third reading. So in that sense, it is felt that this is probably the best BP apparatus which is at present available, but it's a bit expensive. As I said, the wearable cuffless BP monitoring devices, if you will look at the last line from the guidelines, there is no data to confirm that these devices result in improved patient outcomes, and so we as yet do not advocate the use, although we are sure they will come up in the next couple of years. Now, one other conceptual thing which has happened in the management of hypertension in the last couple of years is we are giving more and more respect to the home blood pressure. Ambulatory blood pressure is expensive, it is cumbersome, it is not very convenient for the patient. But the same apparatus, since we have moved from a mercury, a manual apparatus, to an automated oscillometric device, the same device patient uses at home, because we know in the home, person is spending most of the time there, and we want a combination of the office blood pressure reading, which is generally a bit higher than the home blood pressure reading. And so if you will look here, the home blood pressure criteria for diagnosing hypertension is 135 by 85. This is from our Indian guidelines. Actually the same in 2019, the same values have been given by the European guidelines in 2023. If you are having an ambulatory blood pressure is a device which is actually like a halter which records the patient's heart rate. An ambulatory BP apparatus is a device which is applied on the person. The person carries with him, goes home. Every 20 minutes it keeps recording, and after 24 hours you get a whole chart of the blood pressure readings, because we know it's not only the office blood pressure, but the night-time blood pressure is related to target organ damage. The early morning rise, we know. Most strokes, most heart attacks, they occur in the early morning. The morning erections, it's all because of catecholamine excess, which happens from 4 to 10 a.m. So it's the morning time when our body metabolism is such, when the blood pressure rises and when most of the strokes. So the control of early morning rise of blood pressure, control of night. See, most of us will drop our blood pressure by 10 to 20 percent, whatever is our blood pressure in the daytime. There are some people who are non-dippers. We call them non-dippers because their blood pressures do not fall at night. And it's the non-dippers who have more target organ damage as compared to the dippers. So we are today looking at the whole perspective. What's the blood pressure in the office? What's the blood pressure at home? What's the blood pressure at night? What it is in the early morning? Because we want to effectively control blood pressure throughout the 24 hours. And this is what the guidelines today say, that you may not use it for diagnosis of hypertension, which still you will use the office, but you will use it to diagnose white coat hypertension. White coat hypertension means nothing but the blood pressure goes up when we are recording in our clinics. At home the blood pressure is actually normal or lesser. What is masked hypertension? It is opposite of white coat hypertension. In the clinic the blood pressure is not high, but at home, as the name suggests, it is getting masked. At home the blood pressure values are high, and this is, mind you, more dangerous than sustained hypertension also, because doctor will not treat it and the target. So we want to know which of our patients have masked hypertension, which of our patients have white coat hypertension, what is the total level of control. So this is a precaution which is very important actually. that you should ask your patients to monitor blood pressure for 7 days, never to react to one blood pressure reading. It's a very common problem. Patient records the blood pressure, finds it fluctuation. One of my teachers used to say fluctuation is a sign of life. Anything that is not fluctuating is dead actually. And blood pressure, you know, varies by 30 to 35 millimeters of mercury if you record it on an ambulatory blood pressure recording. So variation, you have to tell your patients, is actually a sign of life. They will record morning, evening for 7 days, have an average of actually 14 readings, and that is how you will use the home blood pressure recording to the best method. This is some work actually which we did. It's a very huge study, the India Heart Study, which we published in the Journal of Hypertension. As you can see, 18,000 patients were taken in this study. Self blood pressure measurement was done. It was compared to the office blood pressure. And then we looked at what is the prevalence of white coat hypertension and masked hypertension. And you'll be surprised to know that almost 15% people have white coat hypertension. And about 20% people have masked hypertension. And this underlies the value of not depending only on the office blood pressure, but using the home blood pressure and then having a collective opinion. And this is one of the buzz actually, most of the latest guidelines, that we give more and more respect to the home. Just as diabetologists give a lot of value to the home blood sugar values, we have started now giving more and more value to the home blood pressure recordings for these two reasons, that white coat hypertension and masked hypertension are not very uncommon. And this is a work actually we published in the Indian Heart Journal, in which we looked at the awareness of actually home blood pressure value amongst physicians in India. And what we found was that only 30% of the people actually were using home blood pressure, and these numbers need to be encouraged by you and me and patients. Actually, the industry needs to develop better blood pressure apparatuses which are available at home, and so that we are able to. And also, as doctors, we need to know what are the criteria for diagnosing hypertension in the office. Only 3% of us could answer it correctly, and what are the reasons. And so these are some of the reasons why it is being used less often. We also looked at this factor at an Asian level also. And most of the Asian countries participated in this. Actually, we published in Hypertension Research last year. And we found, as you can see, most of the Asian countries fare similarly in terms of the percentage of people who are using home blood pressure. And this is, as I said, this needs to go up because there is a lack of understanding of value, there are lack of guidelines, and of course there is concern about the reliability of the home pressure. Ambulatory blood pressure apparatus, we do not advocate for routine use. It is only to be used for diagnosis of nocturnal blood pressure phenotypes. And it can be used in resistant hypertension, but otherwise it has a limited applicability because of the cost factor. And why complicate a thing which can be done very easily, which can be done by you in the clinic and also can be done in the office. So these are some of the reasons. So coming to office blood pressure for diagnosis of hypertension, home blood pressure primarily for maintenance of therapy and to know how your patient is responding, and ambulatory blood pressure for difficult cases who have nocturnal rise, who have had a complication of hypertension, and who have resistant hypertension. What is resistant hypertension? Resistant hypertension is when you have used 3 drugs for treatment of hypertension. One of that has to include a diuretic. So obviously it will include a RAS blocker, an angiotensin receptor blocker, or an ACE inhibitor. It will include a calcium channel blocker and a diuretic. And if still the blood pressure does not come below 140/90, that is called resistant hypertension. The whole philosophy of treatment of hypertension is opposite of epilepsy. An epileptologist wants to use higher dosage of a single drug. In hypertension, you use synergistic effects of multiple drugs which act at different levels. So you use lower dosages of multiple drugs conceptually for management of hypertension, and you combine so that your patients have less side effects and there is a synergistic effect between these drugs. This is a very important slide actually, which conceptually gives you that you have to look at the risk of an individual. We are not treating numbers. We are treating human beings. We are not treating labs. After COVID, this bad habit has come. We started treating labs to a larger extent. look at this. You need to form a holistic opinion of your patient. Of course, values are important. So you have the value, whether it is 130, 140, 160, whatever, the risk increases, actually it goes towards the red. If the person has additional risk factors, the risk further increases. And as I said, more the age, more the risk factor, as you can see in the bottom of this slide. But very important is whether your patient has hypertension mediated. Those who already have effects, they are at a higher risk and you will need to be more aggressive in them. I'll just spend 1 or 2 minutes actually. This is a score system. The sex, males have obviously more coronary disease than females. As we age, as I said, more blood pressure, of course. Smoking is a very important risk factor, and LDL cholesterol. So someone who has multiple of these risk factors will obviously have more coronary disease and more effects of hypertension. And this is what we wrote actually in an editorial in Journal of Human Hypertension. The Western guidelines have now bring in coronary risk prediction score. We do not have a risk prediction score of our country. But what we actually in the end said is the age, sex, lipids, smoking habit and diabetes. Someone conceptually who has a multiple of these risk factors is at a greater risk of having hypertension. Be more aggressive. Treat their blood pressure more effectively. Treat it, bring it down to actually better levels so that you can prevent the target organ damage. These are some of the newer actually risk factors which we are today looking at. They may not be as important as the 8 risk factors that I enumerated initially, but the resting heart rate, it's a very important parameter of longevity of life. People who have higher heart rates, exercise brings down the heart rate. I was reading somewhere the famous tennis star John Bogg had a heart rate of 38. So as you exercise, your heart rates come down because your cardiovascular system becomes more effective. People who are physically deconditioned, they have faster heart rate. So heart rate, low birth weight, frailty, sedentary lifestyle, uric acid is now linked, LPA levels. LPA level is what? LPA is a genetic risk factor. It's a risk factor which is peculiar to South Asians. And this is actually some data that we published many years back in Lancet actually. And we found that Indians who had migrated to England, they had higher LPA levels than the Caucasians there. 2 things they had higher LPA levels and higher insulin resistance syndrome. We are a capital of diabetes, you all know. So these are the 2 risk factors which bring in this peculiar early occurrence of coronary artery disease. So these are all risk factors. Heart rate I have just dwelled upon. And these are sleep apnea, a very important, very peculiar cause of actually resistant hypertension. People who have these autosomal disorders like rheumatoid arthritis, SLE, they have greater risk of hypertension effects. People who have NAFLD, chronic infections, migraine, depression, erectile. So this is what actually the hypertension mediated organ damage. You do a simple ECG. If you find on ECG there is left ventricular hypertrophy. You do an echo. If you find the LV mass is increased. You do a urine routine and you find the albumin creatinine ratio is more than 30. You put them into CKD grades. Simple blood pressure measurement in the upper arm and the lower arm to find atherosclerotic disease and the ankle brachial index, which you should do in your clinics. Retinopathy, of course. And this is actually a later stage. When your patient already has CVA, has had a heart attack, has heart failure, has renal failure, by this time actually a lot of the battle is already lost. You want to actually pick up your patients at this stage or rather even before this when they do not have any of these complications. So I'll just touch for a minute or so on our Indian guidelines. These are some of the factors we have given as to what contains more salt and what contains less salt, because we as Indians, as I said, take a lot of salt. And this is a very simplistic algorithm of treatment of hypertension which we have given in the hypertension guidelines. Younger people less than 55 use A. What is A? ACE inhibitor or a ARB, angiotensin receptor blocker. Younger people have a high renin hypertension. Older people have a volume related hypertension. So in older people you will use a calcium channel blocker or a diuretic. The conventional antihypertensives were beta blockers and diuretics. But because of their metabolic side effects, the newer antihypertensive agents, the RAS blockers, the ACE inhibitors or ARBs and calcium channel blockers are. So step 1 is this. Step 2 is you will combine A with C or D. We primarily combine A with C because we know a calcium channel blocker with an ARB or an ACE inhibitor. We never combine an ACE inhibitor with an ARB. And we today know that the best combination is either an ACE inhibitor or an ARB in combination with a calcium channel blocker. Which are the common ACE inhibitors? Ramipril, captopril. Which are the common ARBs? Losartan. So these are candesartan. So these are some of the agents that you will be. Step 3 is you combine A with C with D. As I said, diuretic, if it is not the second drug to be combined, it should be the third drug in combination. And as I already said, the concept is to combine multiple drugs. And the pathway trial showed us that the best agent as a fourth add-on agent is a mineralocorticoid receptor antagonist, spironolactone. The pathway compared actually beta blockers. See, beta blockers, something that was so high up in the treatment of hypertension, today doesn't even figure amongst the 3 lines. Beta blockers are to be used in very selective indications. Young people with fast heart rate, those with migraine, those with heart failure, and those with coronary artery disease. They are the people where you will be using beta blockers. Otherwise, beta blockers as antihypertensive agents have receded in their value, whereas they have gained in their value in terms of heart failure medication. This is from the American guidelines, which shows these are the agents that you use as first line agents for treatment of. I have already dwelled upon the targets. The sprint trial has shown that we try to reduce blood pressures greater. There is a J-shaped curve. If you bring blood pressures to below 120/70, the risk of coronary events, cerebrovascular events increases. So you do not, the European guidelines have given the lower limit also up to which you should reduce. Young people, you try to achieve lower pressures. In a frail, thin, elderly individual where there is fear of postural hypertension, obviously you will not be that aggressive. This is what we have given the Hope Asia Network, some of the things that you need to do. As I said, the awareness, treatment and control rates you can see in scientific reports published this year itself are so dismally low in our country, and this is where we need to work at actually if we want to control. And this is an editorial in, this is actually a review article in Lancet Regional Health which came, which actually shows that although in the last 20 years the levels of control have gone up from about 15% to 22%, but they are still very low. So that's the reason this implementation research, actually there is more emphasis, and we are now looking at greater task sharing. Rather than limiting blood pressure control to doctors, let's involve nurses, let's involve paramedics, let's use the electronic gadgetry and see extended period prescriptions. And this is some of the works people have done actually on involving staff nurses and others. This is an editorial. I'll end here with 2 important remarks which I think should leave some mark on the minds of the students. To achieve improved control of hypertension, the country should adopt and enforce hypertension screening and diagnosis programs on a massive scale. This is something what we wrote actually in an editorial in Circulation, which is a very high impact factor journal. And another quote from another editorial that we published in the European Heart Journal, where we said protocol-driven standardization of treatment regimens is important. Make it as simple as possible for people. As we just discussed, younger people use ACE inhibitor or ARB, elderly people use calcium channel blocker. Combine A and C. If not, then combine A, C, D. If still not, then combine an MRA. So that sort of an approach has to be developed. And India today has actually started the India Hypertension Control Initiative. And we are lucky actually in our institution to start this on a national basis as the first private sector hospital, which we have called as Hamara program, Hypertension Awareness, Management and Risk Assessment Program. And we are currently actually very deeply engaged in this kind of work, where we can control blood pressure more effectively in our city. Almost 50% people we have screened in the last couple of years, because we have to actually work towards the national program for prevention, control of cancer, diabetes. This is a program which was started in 2010. Earlier we used to have National Malaria Eradication Program, Tuberculosis Control Program, because we were dealing with communicable diseases. As our population has aged, the government of India today realizes that we need to handle these non-communicable diseases because they are responsible for mortality of a larger number of people, and the goals are to reduce CVD deaths by 25% and to reduce the prevalence of hypertension by 25%. Thank you.